You arrive on scene, pulseless, not breathing, reportedly a cancer patient, and a caller who isn't even there yet. Just a voice over the phone saying they didn't want anything done. But there's no paperwork in sight. Without that crucial DNR in front of you, what do? Do you start the resuscitation? Do you wait? This is the ethical and legal dilemma that EMS providers face every day. When it comes to DNR and goals of care forms, when it's clear, it's easy. But when it's not clear, it's anxiety-provoking and intimidating. This is Loud and Clear EMS Guiding Principles, and today we're going to break down those challenging scenarios with an expert in hospice and palliative care. Let's get into it.
Let's start by saying this. The vast majority of hospice patients are DNR, DNI.
Can we view these forms as though we're hearing the voice of the patient?
I'll be honest, most forms have a ton of text.
And if you see that, please have a conversation with the facility staff or the patient and the family.
They may not want to make these decisions with a paramedic, and that's not because any of us are bad paramedics.
Just because we're not going to necessarily provide a treatment doesn't mean we're going to do nothing. But first, I wanted to tell you about today's sponsor, the Tailor. For so long, EMS systems have started with a bag and then tried to figure out how to make all their equipment fit into their bag. This is backwards and leads to inefficient systems. We need to start with the necessary equipment to accomplish the desired mission and work backwards to create a bag that works for that equipment. A bag that has a specifically designed spot for each piece of equipment. But not just any spot, a spot that makes sense for the flow of a call. A spot that can also act as a mental checklist on the call or before the call so you can quickly tell if anything is missing. Enter the Tailor, whose mission is to improve patient outcomes through design. If you're tired of your current jump kits not quite doing the job you need them to, reach out to the Tailor at theresusstailor.com to see if they can help you design better outcomes for your system. All right, let's get into today's episode.
You and your partner are working an evening shift and it's 6 p.m. You're called to a 6th floor apartment where there's someone pulseless and apneic on the kitchen floor. The person that called 911 isn't even there. All you know is they say the person is in hospice, they don't want anything done, and they're coming right away. You get there, you check, there's no pulse. They're not breathing. You look around, you don't see any paperwork. And the last you heard was that the person calling 911 for the patient said, "Oh, and the hospice nurse is on their way with the DNR." What do? How do you proceed? Do you initiate care? It sounds like this person's wishes were for none of these things to happen, but why are you there in the first place? They obviously look chronically ill, and you heard they were a cancer patient, and that jives with things you're seeing in the home, like home health supplies, medications. And just as you're taking all this in, the friend does show up and confirms, yes, they have cancer. They don't want any of this done. I've called the hospice and the nurse is on their way. So what do? How do you proceed? Do you initiate resuscitation? What other questions do you want to know? What other things do you want to try to find? Well, this is an incredibly difficult situation that we are faced in the outside of hospital environment. Thankfully, there are incredible resources available to us to learn about these situations, like our guest tonight. He's Dr. Daniel Markwalter. He's an attending physician in the emergency department at the University of North Carolina, and he's also fellowship trained in hospice and palliative care and sees patients in those services also at the University of North Carolina. Dr. Markwalter, thanks for being on our show.
Yeah, thanks for having me.
I am Will Berry. I'm a practicing flight paramedic in North Carolina. My co-host Ross Orpit is an attending emergency medicine physician in Southwest Colorado, and our goal is to bring you guys some of the best education we possibly can. So, Dr. Markwalter, you heard the case. What are some of your initial thoughts?
Yeah, I just want to echo that these can be extremely challenging, in particular because you all know better than I. You arrive on the scene, and there's still sort of this. There are sometimes more unknowns than knowns, right? And you're getting information, and you're not sure entirely what's accurate, and you're waiting for more information to come. But you have to make some decisions in the moment. And so my initial thoughts were well, let's start kind of overview, which is, folks on hospice care, the vast majority are receiving their care at home. I think there's like this misconception that like in the community sometimes that hospice care is like a place, but as you all know, you're probably responding to a lot of these calls at home, right? So the vast majority of these people are at home, and some of them are living independently. It's not that there's a hospice team there 24/7 taking care of them. So when things happen, to patients on hospice, acute changes, they're instructed to call the hospice agency, but sometimes, the hospice agency may take 30 minutes, an hour, 2 hours to get out there, depending on what they're dealing with. Even though they're on call 24/7. And so it's not uncommon in moments of sort of crisis and panic for patients or families to call 911, and EMS is the first on the scene. And so this just sounds like something that could happen every day. You know what I mean? That's sort of my initial thought. But for me as the hospice physician, several thoughts come to mind. One is, yes, the philosophy of hospice is to provide comfort and quality of life at end of life. And often that is avoiding things like resuscitation, transport to the hospital, that sort of thing. But it may come as a surprise to some people that, frankly, not every patient on hospice has a DNR, DNI. So like one of the first things I was thinking about in this case is like, we're told, DNR, DNI, but that's actually not a requirement for patient on hospice.
Now, embarrassingly, I'm going to have to admit that I actually didn't know that as an emergency medicine physician. In fact, I just a few weeks ago was working with a student who came to me and told me they're presenting this patient, said he's on hospice, but he tells me he's a full code. To which I responded, no, that's not a thing. If he wants to be a full code, we'll just do everything and treat him as a full code. And now I'm very embarrassed. I'm going to have to go back and tell that student that I was wrong and correct myself. So can you expand on that a little more?
Yeah, for sure. There's, I think, some historical reasons behind it, but let's start by saying this. The vast majority of hospice patients are DNR, DNI. Like it's a minority that are full code. And part of it is an intention to not sort of, limit to put limits on who's going to get hospice care based on factors beyond their prognosis, right? So like the sort of CMS criteria for hospice really has to do with a 6-month prognosis. And that's like the big criteria. There are patients who live longer than 6 months. There are certainly patients who live shorter than 6 months. But it's that the prognosis is regardless of their code status. And so, we find that there are most of the time patients are DNR, DI, but those patients who are full code, I assure you that the hospice agency over time is having that conversation about their code status. And I've been involved with these over time with patients. And part of it has to do like with, where's their thought process at with sort of the dying process. And some people understand that their prognosis is limited, but are okay with sort of a comfort focused, plan of care, maybe not receiving cancer treatment anymore, not going to the hospital. But there's just sort of this feeling that being DNR, DNI is sort of like
maybe like giving up almost.
It's like resigning myself to death, which is really not how we have a code status conversation. Like when we have a code status conversation with somebody, we're really talking about aligning their plan of care with their goals of care. So like if their goals are comfort and quality of life and spending time with their family, our conversation for code status is about, well, given your metastatic cancer, the outcomes from a resuscitation would not allow you to have that time with your family. And so we try to like align that. But that can take some time to have that conversation. And so that's why there's like patients who are full code on hospice, and the hospice agency continues to have that conversation. And frankly, most patients over time, as they get sicker, some of that's just like they have to see how their disease process is playing out. And as they get sicker, that code status conversation becomes easier in a sense. And most end up being DNR, DNI by the end of life. And certainly, again, most patients are receiving their care at home. But if a patient's coming into a hospice unit, we're not coding people in the hospice unit, right? Like by the time they're needing like inpatient hospice care, we're having that conversation, and they're DNI at that point. So that's a long-winded response to say, to be accepted on hospice, you can be full code, but that conversation is going to play out while they're on hospice with us. And by the end, most patients are DNI.
I want to talk more specifically about DNI because I think for pre-hospital providers, that's the thing that gets harped on the most is the actual document. Can you go into specifics about these documents broadly, and then maybe some nuances that might exist specific to where you live?
Yeah. Broadly speaking, DNI forms fall under that category of advanced directives. So this is a very big category of documents, of which, and we can get into some of these. So advanced directives is anything that sort of maps out somebody's, medical goals or limitations or whatever word you want to put on it. And within advanced directives, you have DNI forms. You have sort of that like more legal sort of, lots of states have their own like advanced directive. Like we live in North Carolina, and there's like a North Carolina advanced directive that's sort of a legal document. And then there's most and post forms as well. And so all those fall under advanced directives. But the DNI forms, or the code status form, takes on different flavors in different states. But that is, as you all know, purely focused on code status. And it's interesting because at least in North Carolina, that form doesn't have to, be signed. Like you need to have a conversation with the patient, but it's not like the North Carolina Advanced Directive. It's not like a most or post form. Like it's just a signature from a physician for that after they've had the conversation with the patient. And then they can designate sort of how long that code status will last. So sometimes you can check a box that just says like no expiration. And so until they change that, they're going to be at, that code status.
So are these forms the patient's wishes in a written document? So like, can we view these forms as though we're hearing the voice of the patient?
Medically, binding documents, they're signed by the patient, or in the case of the DNR form or a post form, like they're signed by a physician or nurse practitioner or somebody who's legally allowed to sign the form. So yeah, they're both the voice of the patient. The assumption there is that a conversation happened to result in the formation of that document. And I would say from an EMS standpoint, y'all are covered and can just assume that the conversation that happened with that document was a good conversation and an accurate conversation. It's not on you to necessarily verify the quality of that code status conversation, because y'all probably not going to know that. But there's a document that then it's y'all are supported. It's both. It should reflect the patient's wishes and be supported by whatever physician signed that document.
And talk to me about the presence of this form, because that is harped on so much in test questions and protocols and scenarios. If the form isn't present, then you almost have to imagine that it doesn't exist, which on a certain level, depending on other factors within the call, that's true. If you have a relatively healthy patient and everyone's saying like, oh, they don't want anything done, you are using some of your street smarts there. But yeah, can you speak about just the necessity of the form to be physically present?
This is interesting to me because there's some slight differences between sort of what happens in the field and then some of the, maybe a little more flexibility that I have, like as a physician, when the patient's in the ER with me and this question comes up. I mean, I think most EMS agency protocols, I think the form needs to be available. Locally, that's the case here in the county that I work in. And I think the reasons are understandable, which is like, our if there's any uncertainty in a circumstance, we should err on the side of doing as opposed to not doing until things can be clarified. And yes, that sort of like feels me a little bit on the inside as like a hospice physician, but that's sort of like even like that's putting my ER hat on. It's like if there's gray area and we don't know if the form's not available, then it's appropriate to err on the side of resuscitation and doing until we can verify that document or whatever it might be. Now, that's not to say that, I mean, there's certainly circumstances where in the field it becomes very evident that perhaps this patient does have, metastatic cancer. They have terrible cachexia. You arrive on scene, they're already pulseless. You just have a sense of like medically this person's very sick. The outcome's going to be poor, and perhaps you're hearing from family, maybe like in the case that you shared, you're hearing from family that this is not what they want. That's absolutely why it's appropriate to hop on with some medical direction with the agency, or sometimes I get calls when I'm sitting at UNC to our just sort of like phone, hey, we've got the situation. Do you think it'd be appropriate to terminate resuscitation? And we can talk to to whoever's there and help provide some guidance. And certainly we've terminated resuscitation in that way. But from the on-scene EMS standpoint, it's resuscitation unless there's a form there. But if you have concerns about it, it's okay to start that conversation and hop on the phone with medical direction.
Back a little bit to the forms themselves, are there any main differences between the different forms that would matter in the pre-hospital context?
Yeah, good question. I have several different thoughts, and I'm not familiar with every state's forms, but I'll just kind of go down the line. So one thing that just comes to mind that sometimes comes up, like in North Carolina, our like DNR form is this like big golden form. I'm sure you're familiar with it. But in North Carolina, I believe it just says like do not resuscitate. It doesn't really mention like intubation. So sometimes there's this like question of like, what does that form cover? And I will say that like practically speaking, most people use it to refer to both. Some states I think are a little more clear about how they word that. But in terms of what it covers, like the DNR form, in my opinion, covers resuscitation and intubation. And that's how I approach the conversation with families when I'm talking to them about it. I frequently link the two. Now, if there are some subtle circumstances where perhaps a patient doesn't want resuscitation, but maybe they have a history of like COPD or some airway disease where they've expressed that they would be comfortable with intubation to stabilize their pulmonary disease, because in theory they could like get their COPD exacerbation under control and then be extubated. And so there are some rare circumstances in which we've had some patients be do not resuscitate, but okay for intubation in the circumstance of like respiratory distress. But I would say from an EMS standpoint, if that's going to happen, it needs to be documented. There needs to like one of these other forms, like a most form or an advanced directive to help clarify that. Otherwise, I would assume that a DNR form is both.
So I kind of get the idea of a DNR form in that, as you're saying, I don't want to be resuscitated. I don't want to have to go through that or have the chance of a poor prognosis and living in a vegetative state. What about these other advanced directive forms or the most or the pulsed? What's the purpose of these?
Yeah. And you hear us using different like terms because every state has, some are most forms, some are pulsed forms, some are post forms. It's sort of this paradigm that's occurred in the last few years of they stand for either like medical orders, for scope of treatment or physician orders for life-sustaining treatment. They go by different names, but those are intended to be truly physician orders. If I was at the hospital writing orders in the medical record, but it's a paper form that can go with the patient and is transportable is essentially the idea behind it. And they are intended to provide a little more guidance on exactly what the patient would and would not want, even beyond code status. The majority of those forms they have a couple sections, start with code status. And so full code, DNR, DNI, and they often will have a corresponding code status form to go with that if they're DNR, DNI. The other sections that are often included on that are, the other one I think is like probably the most relevant to EMS practices. There's a section about sort of, usually gives three options: comfort care, sort of limited scope of care, and then full scope of care. And so the idea behind that is, those with the comfort care box, many of the forms actually even specify basically try not to transfer to the hospital, essentially, like provide care in the location where I'm living. And then the second option, the sort of limited scope, Those are people who are typically okay with transport to the hospital, but want to provide some limits on what. So they may not want to be in the ICU. They may not want to be on pressors. Maybe they're okay with oral antibiotics, but don't really want to be on IV fluids and IV antibiotics. So they provided some limitation. And there's full scope of care, which is just, I'm fine with everything, going to the ICU, pressors, intubation, all that jazz.
What has been your experience with the comfort care checked box? Because I will anecdotally say my own experience is, one, EMS providers bring me a patient and hand me a MOS form that they haven't looked at. And at the bottom is checked comfort care. And under that comfort care, it says, please only transport if comfort measures can't be met at the current facility. And when I ask EMS providers about that after they've brought me one of these patients, they don't even realize that that's what box has been checked on the form. So first and foremost, please look at these forms. And if you see that, please have a conversation with the facility staff or the patient, the family. But the flip side to that is when I then have a conversation with the family or patient about this, they don't actually mean that. They often tell me, oh, I didn't realize that's what that meant. I actually do want more than just comfort to be made comfortable.
We'll go through several pieces of that. So one is I absolutely agree. I think if these forms are present in the home, it's important to read them. And I think actually even more than that, and one reason I think a podcast like this is helpful is familiarizing yourself with what's on the forms before you're in a circumstance where you have to read the form, so that you know like what the options are and what they mean. So that because I'll be honest, like most forms have like a ton of text and things on them, and in the heat of the moment, it can be kind of overwhelming to try and sift through that and figure out what is meant. And frankly, there's sometimes most forms where things even internally on the form seem kind of inconsistent with something. Like one thing will say comfort care, and then but there will be a box that says like okay with like feeding tubes and IV antibiotics. So sometimes they're incongruent. And so just familiarize yourself with the forms beforehand, to your first point. But to your point about families saying, well, that's actually not what I meant, is it gets at, I think, one of the biggest problems with advanced directives. And this has been increasingly written about in the palliative care literature. And I hate to wade into this on the podcast because we could do a whole other talk on this, is how useful are advanced directives anyway? This is like an ongoing conversation and probably not the scope that this needs to be. But that's exactly right. It's because if they're so dependent on the actual conversation that occurred. And to me, that's the most important thing. Like documents are helpful if they can provide very clear guidance. And so that's why I think in the field for EMS, it's helpful if DNR forms are typically less controversial. Things like the MOS form, where they're setting limitations on like IV fluids and oral versus tube feedings and other things. Those are so situation dependent that when people are filling out these forms, they're like, they may have envisioned one thing, but when the moment actually happens, they feel differently about it.
I've seen EMS providers get spun out before on, well, I can make this patient comfortable with, fentanyl, but I have to give IV fluids potentially to administer the fentanyl. And it's like, you're missing the forest for the tree. It's just like, you're overcomplicating this. And the other thing is like there's this practical element too, where I've been in a situation where you could have clear as day on a document what the patient wants, but the facility is saying they're too unstable to be here now. And it's like, well, yeah, where else are they supposed to go? Like it's just these really difficult circumstances that you get in.
Yeah, that's a nice segue into sort of where I was going with that, which is if in the field or in the ER, there's this either, I'm going to use the word conflict. That's not really conflict, but maybe some disagreement on what the intention of the form was, or maybe that's not what was meant either by the patient and family, or the facility is not so comfortable with what's on the form and the proposed plan. I think it's always most helpful to start with, and it doesn't have to be a long conversation, a conversation about like, well, what was the context in which this form was filled out? Does anybody know that? And often, especially if there's family there, most of the time we try and have these forms filled out with some family or somebody present to help sort of guide in the future what's going on. So I think it's helpful to figure out what the context of filling that form out was. Because in the moment when things get heated, a facility or family or the patient may start having other opinions about what should be done. And that's okay. But sometimes when things get really heated like that, when we like bring everybody back to like, well, what was the intention of this form? Like, what is the philosophy of care we're looking for? And I feel like more times than not, if there's a form that really is like all filled out for comfort, when you like drill into it with them, everyone realizes that should still be the goal once you kind of get into what that conversation is. And then you can provide some guidance on, okay, here's what our next steps should be if we're going to continue to align with that goal. But I think exactly right. It's either like in the moment, people get stuck in the trees, or like when a patient looks really uncomfortable or they're very unstable, it just makes everybody uncomfortable. And so we like realign with what the philosophy of care needs to be. And okay, maybe it's comfort. And then let's come up with a plan. And perhaps that plan still is like, we can't provide for that comfort here in this facility. Let's get them to the ER. We can provide some comfort focused care there, and then can either continue in the hospital, or there are a lot of ERs that can then transition people to hospice from the ER. And so we can still align with that sort of philosophy and make everybody feel okay about it. But I think starting with exploring, like, how did this form come about? What was that conversation, can be helpful to jumpstart us back in the aligning with the goals on that form.
Yeah, I think that's really good. Going back to the goals that initiated that form and what the patient's goals are, or what they would want if they're not able to speak for themselves versus what the family's goals are. And also, I think people don't always realize the discomfort that some of our treatments cause, and kind of discussing, what the discomforts of the potential treatments that you're offering could be, and do those align with their initial goals. And also reassuring them that just because we're not going to necessarily provide a treatment doesn't mean we're going to do nothing, that we're still going to treat their comfort and aggressively treat their comfort.
You should be a palliative care doctor, man. So, yeah, I think you said two really great things, and it's challenging to communicate these things in the moment. And I give so many props to our EMS crews in the field. Like, this is such a challenge, but sort of like at the most basic level, communication in palliative care for me is about, one thing, which is we, either doctors or the EMS team, have some medical knowledge. So we have some understanding of what the risks and benefits of a treatment are, maybe what the burdens of that treatment are, and have some more just gestalt about how this patient is doing medically, and aligning our medical understanding with whatever the preferences and values of that patient are. And so that's why I think if we can hone in on what was the context for which this form was made, if we can identify what that philosophy of care is, we can use our medical knowledge to make a recommendation to say, hey, now I'm hearing what like your husband's preferences might be. I say, thanks for helping me understand that a little bit better. Is it okay if I make a recommendation on what we should do next? And 9 times out of 10, everyone's going to be like, please, like, give me a recommendation. What should we be doing? And then you can use your medical knowledge to say, here's the plan based on what I can do that I think aligns with the goals that you're telling me. And then I say, does that sound okay to you? Because that gives them a chance to say, yes, that sounds great. Or actually, for this reason, I don't think that's going to work. And that way you're trying to plug in your medical knowledge with whatever sort of philosophy of care they're trying to like achieve. And maybe that can help sort of resolve the situation and make everybody feel better about it. And again, that might be, we provide care in place. Maybe it's your own hospice. The hospice team is on their way. Let's try and provide some comfort medications while we're here as an EMS team. And then we'll coordinate with the hospice nurse when she arrives and can do a handoff maybe, or whatever it might be.
Oh, yeah, that's really good advice. I really like that idea of combining your medical knowledge with their goals and seeing if the two can jive. And I think ultimately, we've done a lot in allowing patients to make decisions and sharing decisions with patients, which is really, really good. But oftentimes they also want your expert opinion. And so I think, allowing them their own autonomy while still providing your opinion can be really, really good advice.
Yeah, I think that's exactly right. And part of what you said, too, is helpful, which is like, education goes a long way. So sometimes when patients or families are asking, can we do X or can we do Y? Like, it's not their fault. I mean, not medically trained, but they may not understand like what it means to do X and Y. And so that's why I think applying our medical knowledge to the situation is helpful. And it's always funny to me that with these issues around sort of goals of care, not even just end of life care, but goals of care, there's understandably a lot of respect for autonomy, but there are so many circumstances where, let's say a patient has like cholecystitis, like the surgeon's going to come down and recommend cholecystectomy, right? But that's because these feel like big issues. Like medical teams are not trained to make recommendations about some of these more global goals of care issues, but we do it all the time for other medical things, like, oh, you have an abscess. We recommend that we drain that abscess. It's the exact same thing. You just take what your medical understanding of the circumstance and the only difference is you're trying to incorporate whatever the preferences and values of that patient are to then make that recommendation.
Yeah, that's a really good point.
Yeah, it's manipulative if you make a recommendation that does not align with the goals of care and try and spin it like it aligns. You're not supposed to inject your bias into the situation. You need to look at it objectively and make a recommendation to align with those goals, whatever it might be.
These are great tactics for conversations that we're discussing, and they should be had with family members. I think sometimes we get called to facilities where there are care providers who potentially don't really know what to do with these patients either. They're calling 911 because they're seeing acute changes. And so trying to convince the care provider at a facility that they don't need to go to the hospital for X, Y, and Z is just the wrong conversation to be having. To get that patient's family on the phone and say, hey, introduce yourself. You're with EMS. You're a paramedic. This is what you're seeing. Here's what you can do as a paramedic in the field. This is what transport you are able to provide, and see what aligns with them. And that's also going to involve the staff at that facility as well.
Yeah, that's exactly right. There can be so many different inputs in these circumstances, whether it's the facility. Frankly, sometimes the patient fully has capacity and you're getting other inputs from the family. But whatever we can do to bring that focus back to, if the patient has capacity, to the patient, or if the patient doesn't have capacity, to the family's understanding of that patient's preferences, bringing it back to whatever the patient would want in this circumstance is always needs to be the reframing. And it's because you're exactly right. It's so easy to when that facility is to tell you all these other things about the things they're worried about, go back to square one. What's this about and what's it mean for the patient? And then let's come up with a plan.
Yeah. Talk to me about the concept then of when family wants to override the wishes. I'd like to get into that because I think EMS providers have been in those situations where they believe they're doing the right thing. They have a patient that has, let's say, a DNR, and the patient's in cardiac arrest. And they're saying, I have the form. They're in cardiac arrest. I don't have to resuscitate. And now here we are at this pivotal moment that maybe they've discussed, maybe they haven't. They have this paperwork about it. But here we are in this moment, and the family is saying, no. I don't care what's on that paper. I want you to do everything for them. How do we navigate that? First off, a question: can the family even do that?
Yeah, legally speaking, so long as they are the legal appropriate surrogate decision maker, they can. And I use that language because every state's a little bit different. Like if they have a form designating a surrogate decision maker, then that's the person who should be making decisions. In most cases, it's a spouse, but not always. If there is no legal documentation in most states, then it's going to be the spouse that's next. But every state has their own sort of hierarchy of people to turn to as surrogate decision makers. I would say step one is making sure if somebody's telling you something to do that's different, make sure it's actually somebody who could make that decision. Because we definitely have circumstances where people come into the ER saying, I am the healthcare power of attorney, but there's no documentation to go with that. Or it's family members who aren't the direct next of kin. And so step one is making sure whoever's telling you this can actually make that decision. Because if they're not a legal decision maker, then you're still going with the form, right? Because the form reflects. But I think the conflict here is often between understandably, like our own moral distress and the potential for more moral injury in the EMS teams and the ER teams about providing resuscitation to people who may not want it and may have a bad outcome from it. That's where this comes up versus, if families saying, no, like, oh, they didn't know what they were talking about, or that doesn't actually align with what they would want. That's like the tension, right? Which is you got this form and you don't want to do something against somebody's wishes versus what somebody's saying. Just like I said before, if there's any gray area, if there's any doubt, for better or for worse, we should err on the side of resuscitation. If that person who's trying to override the DNR DNI is truly the person who can make that decision, because legally they're allowed to. I think that's probably the main point there. But the more subtle answer is what we talked about before, which is I would explore the conversation around that DNR form with them if they're the legal decision maker. Because this happens even all the time when I'm on the palliative care consult service in the hospital, which is we get called like suddenly the patient loses capacity and family wants to change all the goals around. And they're not trying to be malicious or, most of the time it's just like their own sort of distress about what's going on. But refocusing people on what the conversation was around that form, refocusing people on prognosis and having a conversation can often help realign those goals back toward the form as it was originally intended. And so as crazy as it sounds, that might be a circumstance in which, the spouse, who is the legal decision maker, is saying, no, please provide resuscitation. And perhaps you start resuscitation, but somebody's continuing to have that conversation with the spouse about the form and about whether the wish is really aligned with that form or not. And then if it's found that, oh, yes, actually we have realigned with that form, then terminating resuscitation. But I think whenever there's that gray area, if there's somebody to make that decision who can legally make it, then legally we have to follow that person.
What are some good questions that you have to help elicit this conversation with the surrogate decision maker?
I'm going to say several different options, and I'm not saying you have to use all of these. It's sort of like plug and play a little bit. Like you just have to figure out kind of what the right sort of phrasing is in the moment. But sometimes those questions are, so first of all, 30,000 foot view, I would say most palliative care doctors are like really part of what we do and focus on is exploring illness understanding. So part of it started with like, ma'am or sir, like what's your understanding of, his or her medical condition? And just like hearing for a moment kind of what they understand is going on, both acutely, if they're in cardiac arrest, but also chronically, like what have the last few weeks to months been like? And what's your understanding of what's going on medically with this patient? Because often you'll find that there's room to provide some education on what's going on, which can then inform prognosis, which then informs the code status conversation. So there's like this sort of adage in palliative care, like
you have to like put the ball on the tee before you hit it.
Yeah. Before you hit it. And so part of that is saying like, thou shalt not have goals of care conversation without prognosis. Like there's no context for code status or any goals of care if a patient or family don't understand like what's happening to the patient and what the prognosis is, because that conversation is so different from like a healthy 20-year-old with no comorbidities to somebody with end-stage renal disease who has metastatic cancer. Like that conversation is so different about what the outcomes are and that risk benefit. Exploring illness understanding allows you to then talk about prognosis and expectations for resuscitation that then might help you realign back with that DNR form. Is that helpful, Ross?
Yeah, for sure. So start with kind of an understanding of the illness and the prognosis. Where do you move from there?
From there, I talk briefly, and these can happen relatively fast. I know it's like in the moment, you're like, want to get these things done, but they can happen relatively fast, which is some mix of understanding what their functional status has been like recently, and also what their, because that relates to their current quality of life. So like what their quality of life is like currently, and what their quality of life and goals would be like. So simple questions like, tell me what's important to your husband. Tell me what's, what does a good day look like for him? What does a good quality of life look like for him? When was the last time he had quality of life at that level? Because you might find out that the last time somebody was living at the quality of life that they were really wanting was like 2 months ago. You know what I mean? And it may come out in this conversation. Oh, yeah, he's actually been really unhappy the last few months about his loss of, he's no longer able to ambulate. He can't visit his grandchildren anymore. You may find that quality of life has been changing over the last little bit. And that also informs that code status conversation, because you can then talk about prognosis with resuscitation and say, it sounds to me like he hasn't been living at that quality of life he'd really be looking for. And I don't think that further attempts at resuscitation would allow him to have that function or that quality of life that he's looking for. And so I'd recommend that we continue with what was on this form, this DNR DNI form, and allow for a natural death. That way you can put that illness understanding piece together with the quality of life considerations and what you know about potential outcomes from resuscitation.
Yeah, sort of trying to elicit that, what are we hoping for in this moment? Or what outcome are we looking for?
People who aren't exposed to medicine don't have a full understanding of what the outcomes from resuscitation are like. So yeah, exploring that hope, what are we hoping for? What are we looking for? And sometimes it's a matter, maybe they're not coding yet, but maybe they're you can tell that they're in their dying trajectory, right? Hours to days, maybe. Then I pivot the conversation to a statement I'm really worried that your husband is dying. I think we should be very, our headline with these things needs to be short and concise, be very compassionate but blunt about these things. I'm really concerned that your husband is dying, and I want to know what we should be focusing on if his time is short. And that can then elicit sort of this conversation about okay, what can we pivot to? What would be important to him? And then that can also sort of restoke that conversation a little bit.
Yeah, that's an amazing quote. I'm really concerned that your loved one is dying. What did you say? What should we be focused on?
What should we focus on if his time is short?
If his time is short. Yeah, that phrasing is very good and toes a line of being short, concise, but also clear, and it's direct.
Yeah.
I think one of the other things getting at too is, we've been talking about the patient's wishes, which is good. We should focus, redirect conversation back at that. But you're also treating another person in that room, and that's that family member who's going to be grieving and going through this. And so I think trying to elicit what's going on with them? What are their worries?
Yeah, I think that's a huge piece of this. So we kind of term that anticipatory grief. Oftentimes, families understand that their loved one is really sick, and they're grieving even before that patient dies. And so there's that, again, that anticipatory grief. They're already thinking about that loss, the things that are going to change in their life. And those are heavy emotions. And that's what's sometimes prompting these questions of well, can we do this? Or maybe we actually should do resuscitation. And these sudden shifts at the end of life are often coming from that place of anticipatory grief. And so I think it's not only refocusing on the patient, but how you can care for that person emotionally. And sometimes it's acknowledging and naming emotion. So I saying, because often they're cheerful, right? I can see the sadness on your face. Tell me what's on your mind. Tell me what you're worried about right now. And sometimes they're worried about it's just that they're worried about their loved one, being uncomfortable at home. I understand he's dying, but I don't think I can provide for his comfort here. And then that's a wonderful thing to hear, because then you can come up with a plan. Okay, maybe we do go to the hospital, and then we can come up with a comfort plan there. So Ross, I think that's a great point of acknowledging the emotions that loved ones might be feeling to help identify what those concerns are, because that may help. It's not about getting them on board, but it may help them align with whatever plan makes the most sense for that patient.
So if any pre-hospital providers are interested in going deeper in this topic, what kind of resources are out there for them?
One, I would say there's definitely a growing movement to get both like local agency and state palliative care protocols made. And so exploring whatever sort of your state EMS protocol directory is. I think North Carolina came out with one a few years ago. But beyond that, there are several great palliative care organizations that have like online modules and things to help sort of teach basic, I say basic, but like these like principles of like serious illness communication to help hone those a little bit. So I would say one of my favorites is CAPC, which is the Center to Advance Palliative Care. Their website is like capc.org, has online modules for any number of things. I mean, symptom management, basics of hospice, communication skills. So just like have at it with those modules, as they are wide ranging and I think relatively high quality. So I think that's probably where I would start. If it's communication in particular you're looking for, there are a few, like Vital Talks is one. Vital Talk is a group that I think you have to pay for that if I'm not mistaken, but can do like a more intensive training in serious illness communication. And so I'd say that's not like the tier thing. Like I would look at your like local and state protocols. And then I love CAPC. So like go to CAPC and see if there's any modules on CAPC, which is, CAPC.org.
Yeah, and this is a different CAPC than what EMS providers may be familiar with, which is the accrediting body for continuing medical education. So no, this one specifically is CAPC.org and is a palliative care website.
Excellent. I was not familiar with the other one. So good. Yes, good clarification. Yes, CAPC, CAPC. And there's like a whole resources section. There's like areas on, clinical training. There's just all manner of resources on there. And then, yes, if you really want to take a deep dive, there are groups that will do serious illness communication. And Vital Talk is like one of the most well known.
And going one step even further into that, I heard you mention the concept of symptom management. Can you speak to that some?
Yeah, totally. So perhaps it would have been good to lead with this, but we talked a lot about end of life care and hospice. Hospice is truly the end of life care side of things. I mentioned like it is really an insurance benefit that's about 6 months. Quality of life, comfort care at the end of life, but that's just a subset of what palliative care does. So like palliative care is this like more broad overarching term that is really focused on serious illness supportive care. So the things that we do in palliative care really fall into, I would say like three main categories. One is like the communication, helping people identify their values and preferences to come up with a plan of care. So we did a lot of talk about that. The second piece is symptom management. So because we're focused on, quality of life and supporting serious illness, a lot of that is helping people manage the burden of their disease. So whether it's nausea and vomiting from their chemo regimens, whether it's shortness of breath from their pulmonary hypertension, maybe it's pain related to their metastatic disease. So we do a lot of symptom management, and we'll talk about it in a second. And then the third piece, which Ross kind of alluded to, is the sort of psychosocial support for people and families with serious illness. So those are sort of like, I think, the three main categories within palliative care. Hospice, we use all those skills, but it's just this little niche that is the end of life care piece of things. And so the reason I start with that is because I do know that sometimes there's some confusion about, well, what's palliative care? What's hospice? Like, when is a patient on hospice? What does it mean to be on palliative care? And the piece I would add to that is like, we provide palliative care to people across the whole spectrum of illness. Like, I care for people on the palliative care team who I actually fully expect will be cured of their disease. Like, it does not mean just because somebody's getting palliative care does not mean they have a terminal illness. It just means they have a serious illness and something that we need to help support them through. So we deal with everything from, curative treatment to end of life care. So palliative care can be given anywhere along that spectrum. But a large piece of what we do is managing people's symptoms to provide that quality of life that they're looking for. And so the symptom management side of things, I think, is really important for EMS, because that's actually, I think, a big piece of what in these crisis moments that y'all can offer, because you have tools in your toolbox to help address things like pain, which is, frequently when there's a crisis going to be opioid pain medications. Opioids are also helpful for breathlessness, dyspnea, people at end of life sometimes have intractable nausea and vomiting. So whether you've got Zofran, we love to use Haldol for nausea and vomiting in hospice. And so those are things that you can often provide. And sometimes I know it's a matter of you get called out to a patient's home who's already on hospice, but they're having a symptom crisis. And the tools in the toolbox for hospice at home, they always have an emergency kit with some of these medications in them, but they're oral medications. And so sometimes their symptoms are so bad they can't be managed initially with those oral medications. So perhaps the role of EMS is doing some of that symptom management IV to get their symptoms under control until the hospice team can take over and get them back on an oral regimen. Or perhaps the hospice team arrives and you all decide this can't be managed in the home anymore. Let's get them to our hospice facility, or let's get them to the ER. That was a long-winded response, but sorry. I was starting with the big picture and then focusing on the symptom management.
No, it's incredibly helpful because I didn't understand that distinction.
Well, thank you so much for joining us, Daniel, and providing this expertise. If I can kind of summarize what I heard, and you can correct anything, the principles for EMS providers when responding to these calls are A, recognize these forms exist and ask about the forms. Ask if somebody has one of these forms, read and review them, and make sure that the care you're providing aligns with the goals of the patient that they've pre-set out. If there's any discrepancies in what has been written down versus what individuals on scene are expressing they want done, going back to the conversation that led to that document is a good first step. Illness understanding is another good first step or second step. And then addressing the concerns and worries of the family members on scene are always important as well. If for whatever reason the document does not exist on scene physically, it's a bit of a gray area and judgment call. You're going to err on the side of resuscitation if there's gray area in any of this. But use your knowledge as well. If this is a patient who looks cachectic, has metastatic cancer, has a family member on scene saying they have a DNR despite one not being present, get on the phone with your medical director or your online medical direction and come up with the best, most appropriate plan for this patient.
Yeah.
Anything else you would say?
When you're in that gray area and you feel like you need to have a conversation with somebody about what the next steps are going to be, be curious. It's okay to ask questions about how these forms came about, what's important to that person, and then using your medical knowledge to then recommend a plan of care. Because, as an EMS crew, you have so much expertise to bring to that situation, and bringing that expertise and making that recommendation can take a lot of burden off of family members and patients by giving them a plan. And people like to have a plan. So you can use your knowledge, use your expertise to provide that plan to somebody.
Perfect. Thanks so much. Will, anything you would add?
Yeah, the only thing that I was going to add is we do say this a lot, and I think in the midst of the most gray of situations, one thing to think about too is A, being compassionate, and B, what would you want done to your family member? But I also think as EMS providers, if you're in a being cognizant of your own biases, and when you're in maybe a compassion fatigued state, or you're honestly your jaded side might be flaring up and thinking, this is silly. We know this is going to ultimately be futile. And maybe you start trying to push an outcome that is honestly maybe a little too forceful for the family in the situation. Sometimes you honestly need to fall back to what your protocol is, and not to just do it, not just to be algorithmic or robotic in your care, but allow that to help you. So if you're supposed to contact online medical direction, do so. If the form's not present and you have clear direction about that, then maybe you follow that and relieve yourself of some of that almost emotional burden you can feel when you're trying to potentially force an outcome that you may think is in the patient's best interest. But the truth of the matter is, some family members and patients, no matter how right you may be or feel, they don't want to make these decisions outside of a hospital. That's just the truth. they may not want to make these decisions with a paramedic. And that's not because any of us are bad paramedics. It's just the nature of their care in our healthcare system. They want to make some of these decisions in a clinical environment with a care team around them, or a palliative care or hospice doctor that's familiar to them and their care. And so transporting these patients to the hospital sometimes is going to happen too. And that's not some sort of failure on EMS's part or a waste of time. It's just the right thing to do. But I do also fully believe in the other side, where we can use our knowledge and we can use our experience to have these informed conversations with patients and their family about what their wishes are and where they want these things to go. Because we are there when these moments are at their most raw. And I think we have a very unique opportunity to bring some of that knowledge and perspective into their home, and they weren't maybe expecting that. So a complicated answer, but I think that these situations, one of the reasons I really wanted to talk about this, there's some of the most gray, and there's some of the ones that honestly, as an EMS provider, they've been the most troublesome to me, because the care is sometimes straightforward. It doesn't get any more algorithmic than following ACLS, but when to flip that switch and turn it on, that is sometimes really difficult. And so thank you, Dr. Markwalter.
Yeah, absolutely. This was such a fun conversation, and these issues will be with us for a long time. So hopefully this we can provide some guidance on maybe how to approach these conversations.